Hello, good morning. In the previous class, we discussed nutritional importance of carbohydrates like dietary fibers, glycemic index, etc. And also we discussed some part of nutritional importance of lipids, that is RDA, what are the dietary sources, essential fatty acids, etc. Okay. Coming to continuation of this nutritional importance of lipids. First of all, this class is a clinically oriented class, right? Today's class is more of clinical importance. That means I am going to discuss role of lipids in atherosclerosis. What is atherosclerosis? What is the risk factors? What is the treatment, and etc. And also one more clinically important topic, that is obesity. Of course, it is also comes under nutritional importance of lipids. So one more I want to discuss in brief, that is fatty liver. Coming to role of lipids in atherosclerosis. First we will try to know what is atherosclerosis, pathogenesis of atherosclerosis, etc. Atherosclerosis is a type of arteriosclerosis. Arteriosclerosis means hardening of arteries with loss of elasticity. Atherosclerosis and myocardial infarction are the two major causes for death in Western countries or in developed countries. Atherosclerosis is a chronic, progressive, inflammatory disease involving tunica intima of large and medium-sized arteries by fibrofatty block called as atheroma. This is the definition for atherosclerosis. That means atherosclerosis is a chronic, progressive, inflammatory disease involving tunica intima of large and medium-sized arteries by fibrofatty block called as atheroma. Atheroma is a white yellow material composed of smooth muscle cells, leukocytes, loose connective tissue, macrophages, T lymphocytes, lipids, and lipid ladder foam cells. Coming to pathogenesis of atherosclerosis, and this atherosclerosis is directly proportional to the LDL level, and this LDL is the principal factor in promoting or causing atherosclerosis. The oxidized LDL impairs nitric oxide production and thereby increases its degradation. This oxidized LDL are deposited in the intima of arteries. Plasma LDL is mainly catabolized via ApoB LDL receptor pathway, but a small part of LDL particles are also degraded by a non-specific mechanism like uptake of macrophages. This free radical induced oxidative damage of LDL will accelerate atherosclerosis. Later, the macrophages become overloaded with cholesterol esters and they are called as foam cells, which are hallmark of atherosclerotic plaques. In early stages of atherosclerosis, the condition is reversible if plasma lipid levels, especially LDL cholesterol levels, are lowered. But when lipid is accumulated, the lesion progresses unchecked and the arterial changes becomes irreversible. Formation of atherosclerotic plaques leads to narrowing of blood vessels. This fibrous proliferation due to liberation of various growth factors by macrophages and platelets. Finally, clot is formed which occludes one of the major vessels. Coming to risk factors of atherosclerosis and coronary artery diseases. And these risk factors of atherosclerosis are mainly classified into non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors in brief are genetic factors, sex and age. It is more in females when compared to more in males when compared to females, and it is more common in males after menopausal age, etc. Coming to modified risk factors, the modifiable risk factors, there are three major modifiable risk factors. One is hypercholesterolemia, hypertension, and diabetes mellitus are the three major modifiable risk factors. Coming to hypercholesterolemia is one of the major risk factor for atherosclerosis. Normally, total serum cholesterol should be below 200 milligram per deciliter. LDL cholesterol is called as bad cholesterol because it carries cholesterol from liver to peripheral tissues. Normal LDL cholesterol should be below 130 milligram per deciliter. Value of LDL cholesterol more than 160 milligram per deciliter carries a risk of atherosclerosis. HDL cholesterol is also called as good cholesterol because it transports cholesterol from peripheral tissues to the liver, hence it is called as good cholesterol. Value above 60 milligram per deciliter protects against heart diseases. Value below 35 milligram per deciliter increases the risk of atherosclerosis and coronary artery disease. Ratio of cholesterol HDL-C more than 3.5 is dangerous. LDL-HDL ratio more than 2.5 is also dangerous. Lipoprotein A, it inhibits fibrolysis. LPA levels more than 30 milligram per deciliter increases the risk 3 times, and when increased LPA is associated with increased LDL, the risk is 6 times more. Coming to triglycerides, normally it ranges from 150 to 200 milligram per, 80 to 150 milligram per deciliter. Triglycerides level more than 200 milligram per deciliter is injurious to health. One more factor for atherosclerosis and CAD is cigarette smoking. Increases the risk of atherosclerosis and CAD. Diabetes mellitus is one of the major factors for coronary artery disease. Hypercholesterolemia, hypertension, and diabetes mellitus are the three major predisposing factors for atherosclerosis and coronary artery disease. Homocysteine level, plasma level of homocysteine more than 15 micromoles per liter increases the rate of coronary artery disease and atherosclerosis. Increased HSCRP, high sensitive C-reactive protein, is a predictor of future coronary artery disease. Coming to prevention of atherosclerosis, prevention is aimed to reduce total cholesterol below 180 milligram per deciliter, and also to decrease LDL level below 130 milligram per deciliter, and to keep the HDL cholesterol above 35 milligram per deciliter. This is the aim of prevention of atherosclerosis. And second prevention is dietary restrictions. Avoid egg and meat. Intake of more polyunsaturated fatty acids. Sunflower oils and fish oils are rich in polyunsaturated fatty acids. These polyunsaturated fatty acids are required for esterification and excretion of cholesterol. So polyunsaturated fatty acids helps to reduce cholesterol. Omega-3 fatty acids, linolenic and timnodonic acid present in fish oil also reduces LDL cholesterol. This was already discussed in the previous class, how it decreases. The moderate intake of fat, high fiber content in the diet is advisable, but one should not take high carbohydrate diet. That means high carbohydrate diet should not be advisable. And also moderate exercise is advisable. Keep hypertension under control. Avoid smoking. Coming to treatment of atherosclerosis in brief, administration of hypocholesterolemic agents, statins like lovastatin and simvastatin. These two statins inhibits the activity of an enzyme HMG-CoA reductase activity and thereby decreases cholesterol concentration. The second line of drug of treatment is clofibrates. These fibrates derivatives increases the activity of LPL, that means lipoprotein lipase enzyme activity, and increases the VLDL catabolism and thereby decreases cholesterol concentration. Nicotinic acid is also used to decrease lipid levels. Aspirin is used to prevent thrombus formation in MI. Use of antioxidants like vitamin A is used as supportive therapy to minimize the oxidation of LDL. Coming to one more clinically important topic, that is obesity related to nutritional value of lipids only. It's a very common question also, right? Most common obesity is most common over nutritional disorder in developed countries. And this obesity is defined as excess accumulation of fat in the body. Normal body content of fat ranges from 15 to 20% of total body weight. A person is said to be obese if the body content of fat is more than 20% greater than ideal weight for height. And this obesity is mainly due to increased energy intake and decreased energy expenditure. This is the major cause for obesity. That means it is due to increased energy intake and decreased energy expenditure. There are two types of obesity: upper fat obesity and lower fat obesity, etc. Upper fat obesity is mainly due to hypertrophy of adipocytes, whereas lower fat obesity is mainly due to hyperplasia of adipocytes. And this degree of obesity is assessed by body mass index. This body mass index is calculated by using the formula body mass index equals weight in kilograms divided by height in square meters. Normal BMI ranges from 20 to 25. Depending upon the BMI, obesity is classified into mild obesity, moderate obesity, and severe obesity. Mild obesity is having a BMI of 25 to 29.9. Moderate obesity having a BMI of 30 to 39. In case of severe obesity, BMI is more than 40. Mild obesity is associated with low risk of medical complications. I will come to that complication a little later. Whereas severe obesity is associated with high risk of medical complications. Coming to causes for obesity, if one parent is obese, there are 50% chances of children to become obese. No gene is responsible for obesity. And other causes for obesity are excess intake of food, sedentary lifestyle, repeated pregnancies, use of oral contraceptives for longer period, postmenopausal age, environment factors, and endocrine causes like hypothyroidism, hypogonadism, Cushing syndrome also leads to obesity. The two hormones, leptin and adenopectin, plays an important role in obesity. Leptin is a protein hormone with 167 amino acids synthesized in adipose tissues by adipocytes. The gene for leptin is situated on chromosome number 7. And this leptin acts through its receptors specific receptors present in brain neurons. This leptin regulates feeding mechanism and energy expenditure to maintain ideal body weight. Leptin acts on hypothalamus to release certain appetite stimulating and appetite suppressing neuropeptides. These neuropeptides modulates intake of food and metabolic activities. Leptin also acts on synthetic nervous system, causing coupling of oxidative phosphorylation, resulting in liberation of heat. Coming to one more hormone, that is adenopectin, is another protein hormone consisting of 224 amino acids secreted by adipocytes. It also acts through its specific receptors present in brain. Adenopectin increases glucose uptake and gluconeogenesis, increases insulin sensitivity, and adenopectin also helps in weight loss and also plays an important role in control of energy metabolism. It plays an important role in suppression of metabolic derangements resulting from type 2 diabetes mellitus, obesity, atherosclerosis, and non-alcoholic fatty liver. Some of the biochemical changes in obesity these are the major important biochemical changes in obesity. Number one, in obesity there is an increased number and size of adipocytes. There is an increased serum triglycerides and also there is an increased total serum cholesterol concentration. In case of obesity, increased serum insulin concentration. This increased insulin in turn increases lipogenesis and inhibits lipolysis. Insulin resistance is also associated with obesity and there is a decreased insulin receptors. There may be hypoventilation with increased PCO2. The risk of obesity are hypertension, diabetes mellitus, coronary artery disease, insulin resistance, osteoarthritis, cholelithiasis, cancer, and reduced lifespan are the major risk factors of obesity. Coming to treatment of obesity in brief, dietary restrictions are more important. Use of drugs like amphetamine, fenfluramine, thyroxine, DNP, nothing but dinitrophenol, which is an uncoupler of oxidative phosphorylation. Recently, the hormone leptin and glucagon-like peptide are also used in the treatment of obesity. The two surgical procedures for obesity are liposuction and lipectomy. Just in brief, fatty liver. I am not going in depth because this was already discussed under metabolism of lipids or metabolism of cholesterol. Fatty liver means deposition of excessive accumulation of triglycerides. Don't write fat, you must write triacylglycerols or triglycerides in the liver cells is called as fatty liver. Normal accumulation of fat accounts for about 1 to 5% of total weight of the liver. The two important causes for fatty liver are decreased mobilization of triacylglycerols from the liver or increased synthesis of triglycerides. The decreased mobilization of triacylglycerols from the liver may be due to impaired synthesis of VLDL caused by absence of lipotropic factors, may be due to impaired synthesis of apolipoprotein B and also impaired assembly of VLDL. Increased synthesis of triglycerides may be due to increased mobilization of fatty acids to the liver or increased synthesis of triacylglycerols in the liver. Increased mobilization of fatty acids to the liver is seen in diabetes mellitus and also increased fat in the diet. Increased synthesis of triacylglycerol in the liver occurs after alcohol consumption. Regarding lipotropic factors, biochemical changes in fatty liver already discussed during previous classes. Today we are going to take that interaction class on chemistry of carbohydrates and metabolism of carbohydrates. All of you must be present and you must read and come. Okay, we are going to take one or two interaction classes regarding this topic, right? Okay, thank you.